Hi, everybody. Welcome. We really appreciate your giving us your time today. Please feel free to munch on your lunch as you watch this presentation. Mental Health Association of Rhode Island and NAMI Rhode Island collaborate each year to deliver to the community mental health consumers' top priorities this legislative session. There are many, many bills, but Beth and I tried to select bills that had big impact in the state.
Hi, I'm Beth Lamar. I'm the Executive Director of NAMI Rhode Island, which is the state organization of the National Alliance on Mental Illness. NAMI Rhode Island was founded in 1983 by family members of people who were living with serious mental illness. Today, NAMI-RI provides support, education, and advocacy efforts on subjects related to mental health and mental illness, and our programs are available in person and virtually throughout Rhode Island.
Thank you, Beth. I'm Lori Marie Peixoto, and I'm the Executive Director of the Mental Health Association of Rhode Island. This organization was founded in 1916 by a gentleman named Clifford Beers. Mr. Beers was a Yale graduate, and he worked on Wall Street, and he and all of his siblings lived with serious, persistent mental illness for all of their lives. He spent years living in what used to be called asylums, but we now call them psychiatric hospitals. And when he was there, he witnessed people being caged, being shackled in place. The conditions were filthy and overcrowded. And when he returned to the community, he wrote an autobiography called A Mind That Found Itself. And it chronicled his time in these asylums. And he gained the support of physicians across the country, and it sparked a second wave movement to reform psychiatric hospitals across the country. Mr. Beers actually spent the last years of his life at Butler Hospital, where he died of natural causes. Through his work, he accomplished many federal reforms. And that is what Mental Health Association of Rhode Island continues to do today. We work to increase access to treatment for all Rhode Islanders to improve Rhode Islanders' mental health. Our priority areas are increasing access to treatment and ending wait lists, increasing diversity, equity, and inclusion in our behavioral healthcare system, strengthening our behavioral healthcare workforce, and establishing an Olmstead plan in Rhode Island. And like Mr. Beers, I do this work because I have lived experience of mental illness myself.
Today, we have narrowed down our priority areas for the proposed legislation that we're going to cover into 4 categories of priority. The first is equitable access to behavioral health care. The second is youth mental health. The third is the ending of criminalization of mental illness. And the fourth is preventive measures. And Lori's going to get us started.
Thank you, Beth.
Welcome.
So starting with equitable access to behavioral health care. So we continue to have a wait list for all levels of care in Rhode Island. We know that Rhode Islanders are not able to access treatment and services when they need them. People are prematurely discharged from hospitals, while others are actually stuck in the hospital because there's no appropriate level of care for their release. And the pandemic, of course, exacerbated our workforce shortages in Rhode Island. It increased staff burnout, and it simultaneously increased the demand for treatment and services. But again, these waitlists existed before the pandemic. I can tell you myself, in 2018, I had to go on a brief waitlist for an outpatient therapist. And then again, during the pandemic, I had to go on a 6-month waitlist for a psychiatrist to manage my antidepressant. So this is not new, but it's definitely a problem that is fixable. And that's what we'll talk about shortly. So providers in Rhode Island, when they are underpaid, They take jobs in Connecticut and Massachusetts where health insurance companies pay them higher rates. And that's contributed to some of our workforce shrinkage in Rhode Island. The last 3 years have been very encouraging from the perspective of someone who has been an advocate in this realm. I've seen our leaders in Rhode Island take behavioral health care more seriously and start to invest in the continuum of care and crisis services to help rebuild what we've lost through decades of underinvestment. So it's very encouraging, and I'm grateful for all that our leaders have done to get us to this point. Having said that, we need sustained, significant investment in our behavioral healthcare system each year. And there are many ways that we can do that, and some might cost the state money, but others do not cost the state money. And this next piece of legislation is one of those examples that does not cost the state a penny. House Bill 7716, sponsored by Representative Tanzi, and Senate Bill 2180, sponsored by Senator Loria, work with health insurance companies, commercial health insurance companies. And these pieces of legislation require a one-time inflationary adjustment plus 5%. And this would help increase the number of outpatient behavioral health providers in the state of Rhode Island, because again, it's increasing the wages, it's making these positions more attractive, it's hopefully pulling back some of the providers we've lost to the surrounding states, and it's helping providers in Rhode Island to keep their doors open by giving them the resources that they need to cover the expenses of, delivering the services. And so again, this does not affect Rhode Island's state budget. It only affects commercial insurance companies. What I can tell you is that we hear from our friends in insurance companies that if there are any increases to the rates, they propose raising the cost of insurance premiums to offset that increase in their expenses. What I would say to that, and this has been proven out time and again, is when you increase behavioral health care services at the outpatient level, we can reduce the utilization rates of emergency departments, inpatient hospitalization, and residential treatment centers. And those three are expensive levels of care, restrictive levels of care. And if you invest in the outpatient levels of care and make it easy and quick to get the services you need, then again, you're saving money in the long run because you're paying less for those expensive levels of care. This second piece of legislation, also sponsored by Representative Tanzi and Senator Uji-Fusa. This is our parity piece of legislation. The purpose of this bill is to tighten up the law on various insurance coverage standards, protocols. For example, the definition of what is medically necessary treatment for individuals with mental health conditions, substance use disorders. This piece of legislation was actually modeled off of something that was developed by the Kennedy Forum. And I consider the Kennedy Forum to be the nation's experts on the issue of mental health parity law. So we are very grateful to our sponsors for putting this legislation in. This is the first time it's appeared introduced in our General Assembly. So we're very hopeful that it will move forward this year.
So these next two slides are going to cover this year's proposed legislation that is related to step therapy and prior authorization. Just as background for those who might not be familiar with these concepts, prior authorization is a process that requires advanced approval from the health insurer before a specific service or medication is delivered to the patient. And the issue with prior authorization is that while insurers use this method to manage costs and to assure that whatever the service or medication is covered under the plan, it discredits the clinician's judgment of the best approach to treatment, which can also delay effective treatment, can cause the patient to experience unnecessary side effects and prolonged symptoms of their condition. Step therapy is basically a type of prior authorization for prescriptions specifically. And step therapy requires the patient to first try the most preferred medication before progressing to other options. Usually it's called most preferred because it is the cheapest treatment that is available, and then they move on to more expensive therapies. So on this slide, you will see two different areas of proposed legislation. On your left-hand side, we have the House Bill 7822 from Rep. McGaugh and its companion in the Senate, 2611 from Senator Ujifusa. This would limit the use by insurers of step therapy by allowing step therapy exceptions. In other words, in certain cases, step therapy would not be necessary if perhaps the recommended treatment or recommended medication was proven to be most effective as per the clinician. On your right-hand side, you're going to see legislation in the House in the form of Bill 7897 from Rep. Casey and its companion in the Senate, 2380 from Senator Visalan, which prohibits prior authorization in step therapy practices for the prescription of a non-preferred medication on a drug formulary used to assess or treat an enrollee's bipolar disorder, schizophrenia, or schizotypal condition specifically. So that is specific to mental health medications. Prior authorization and step therapy can be harmful because it can decrease the trust between the patient and the clinician. It can favor cost savings over clinical expertise and patient safety. It can decrease treatment effectiveness and adherence to prescription medication, and it can increase the likelihood of crisis if the medication that was prescribed in lieu of the best medication is not effective. Also, it will overall increase the costs to the patient and to the system by having to try numerous methods or numerous medications until finding the right one. The third piece of legislation in the area of prior authorization and step therapy is in the form of House Bill 7623 by Rep. Tansey and Senate Bill 2614 by Senator Ujifusa, which would require the Rhode Island Office of the Health Insurance Commissioner, otherwise known as OHIC, to form a work group that would study prior authorization practices for all prescription medication. They would then produce a report with recommendations.
Thank you, Beth.
Thank you.
We applaud our leaders for including CCBHCs and 988 in the fiscal year budget. You may recall from last year, we talked a little bit about CCBHCs. That stands for Certified Community Behavioral Health Clinics. And it's a federal model of integrating primary care with behavioral health care. They accept anyone who walks through the door, regardless of insurance or ability to pay. They collaborate with local law enforcement agencies to reduce the number of individuals with serious mental illness from being arrested and incarcerated. They have a unique payment model, which makes them more sustainable than other types of community mental health centers. The 988, you may recall also, is a federally mandated behavioral health crisis line, suicide prevention line. And we're really proud because in Rhode Island, our 988 line has, I think, over a 95% answer rate, and it's one of the highest in the country, if not the highest in the country. So we're really proud of it. It's making a difference in people's lives, and we're so glad to see that our leaders are funding it again in this year's state budget. We were disappointed to see that at the last minute, $1 million for workforce development was pulled out of the budget before it was finalized in the governor's office. This $1 million supported 3 Health and Human Services workforce programs that would help individuals pursuing these careers, to support them, give them scholarships, help them find jobs, and move up ladders in their current workplaces. So it was a missed opportunity in the budget, and we hope that our leaders will work to put it back in. It's just $1 million, but it can have a huge impact on stabilizing our workforce. Also, usually I'll tell you that Eleanor Slater Hospital, I'm not sure what that yellow is. John Meltzer, I'm not sure what is happening, but I'll just finish. Eleanor Slater Hospital's bed capacity is chronically underfunded, as is Eleanor Slater Hospital staffing. We know that our leaders are offering comparable rates to Eleanor Slater's staffing. Compared to what you'll see in other psychiatric hospitals in the state. However, as advocates, we can tell you that the nature of the work at Eleanor Slater Hospital is different than what you would see in other hospitals in the community. The work is, you're dealing with patients who have very complicated medical and behavioral health histories. It's a very stressful environment. There's high turnover. And so in order to address the special nature of working with that population, we really do need to persuade our leaders that we need enhanced salaries and enhanced rates for Eleanor Slater Hospital if we are ever going to fund it fully. And when we don't fund it fully, people who are forensic patients at the Adult Correctional Institute are not able to get beds at Eleanor Slater Hospital, and they wait in the prison instead of being in an environment that would be more therapeutic for them. So there are real life consequences to underfunding Eleanor Slater Hospital. It's an important part of Rhode Island's continuum of care.
So our next area is youth mental health. Some of the problems and causes that are contributing to the national and local mental health crisis among youth are the continued shortage of youth mental health providers and services. Lori has already mentioned a few times about how we have provider shortage in this state, and that extends to youth services as well. Suicide is a leading cause of death among youth. Some youth are facing adverse childhood experiences or factors that can be potentially traumatic with lifelong impacts. There's more information on the risk factors and protective factors that can be found on the CDC's website, as well as lingering effects of the pandemic, which are including, but certainly not limited to, economic impacts, periods of illness and isolation leading to depression, impact on academic performance and developmental setbacks, grief and loss over individuals' experiences, and so forth. And so much more that we don't even know yet because we're still just starting to see what those impacts truly are. The pandemic, of course, also increased the demand on behavioral health professionals and increased the risk factors overall for those who might not have already been experiencing mental health concerns. There's an inadequate insurance network of providers and free care in general, and certainly not enough youth-specific services. Lastly, the reliance on school counselors as a form of behavioral health treatment for youth should not be the only avenue youth have available to them to seek the help that they need. So the proposed legislation right now in the House is 7147 from Rep. Lombardi. There's not presently a proposed Senate bill, but we hope to see one. This bill would require the Rhode Island Department of Education to develop and make available curriculum for up to 4 hours of mental health instruction for 7th graders. This initiative is not only important for early detection and treatment so that youth know when to seek help for themselves, for a loved one, or a friend, but also can help to normalize the conversation about mental health from a young age and help to reduce the stigma in seeking treatment. The other bill pertaining to pediatric mental health in the House, the bill is 7900 by Rep. Fogarty, and in the Senate, it's 2608 from Senator DeMario. This would require the Executive Office of Health and Human Services to establish an early childhood mental health hub program for youth ages 0 through 6, as well as their families. This initiative is not only important because it will help to connect those who need services to existing resources, but also to help break the cycles of negative patterns in families, to decrease the risk of mental health disorders in adulthood if treated early, the early diagnosis of mental health conditions, and sets a foundation for better long-term emotional, psychological, and overall health.
And now I'll discuss pieces of legislation that would work toward ending the criminalization of mental illness. This bill has been kicking around for the past few years. It's called the Medicaid Reentry Act, and I'd like to thank Representative McEntee and Senator Lawson for submitting these bills. Many of you know, but I'll say it anyway. Serious persistent mental illness is an illness that impairs one's ability to live their daily lives, to take care of themselves, perhaps being able to attend school or being able to hold a job or to cook for themselves and shop for themselves and bathe themselves. So this is considered a type of a disability, serious persistent mental illness. And according to the Substance Abuse Mental Health Services Administration's National Survey on Drug Use and Health, in Rhode Island, about 6% of our community population lives with serious persistent mental illness. This could be something like a bipolar condition or a medication-resistant illness like schizophrenia. But this population is vastly overrepresented in our jails and prisons. And so it's estimated that about 15 to 20%, just generally across the nation, 15 to 20% of our prisons have individuals with serious persistent mental illness. And that makes our prisons the largest psychiatric institutions in our state. And you may wonder, why is this? This is because many states, including Rhode Island, we fail to invest enough in supportive housing for individuals who need that type of support. So something perhaps like a congregate care setting, like a group home. And when individuals who have these types of complicated disabilities are not able to secure supportive housing, they often are not able to hold a job, and so perhaps they become homeless. They have contact with the criminal justice system for crimes related to homelessness, like loitering, for example, or shoplifting, and then they become incarcerated. And what this bill tries to do is to reduce the recidivism rate for this particular population, but actually it benefits all inmates in general. Because when an individual is incarcerated, the state takes on 100% of your housing costs, including medical care, including prescription medications. And so in order to help inmates who have been are going to be released from prison, it allows the state to turn on their Medicaid 30 days in advance, even though they're actually still incarcerated. But doing so means that when they step out of prison, they will automatically be on Medicaid rolls, and they can be already connected to housing services and case management services and outpatient psychiatry and therapy and whatever they need, so that they have their best chance at maintaining their recovery and all the ground they've gained while they were living in the prison. And that's why this piece of legislation is important. It helps give them a chance at staying, maintaining the ground that they've built in prison. And that's why this is one of our priorities. Another piece of legislation would reform and provide oversight for the ways that solitary confinement is used in our Rhode Island prison system. In Rhode Island, we don't call it solitary confinement, we call it segregated housing, but it's basically solitary confinement with inmates allowed out of their cell 1 hour per day. So imagine being in a small 6x8 cell for 23 hours a day and only having 1 hour a day of seeing sunshine and having fresh air. And so this piece of legislation has also been kicking around for several years. And again, it tries to provide oversight and some guidance around how our prison officials use solitary confinement. And we thank Rep. Felix and Senator Acosta for submitting these bills again this year.
So the last area of priority that we're focusing on this year is preventive measures. So in past years, there have been bills proposed to mandate that the Rhode Island Turnpike and Bridge Authority would design safety barrier systems on the Mount Hope Bridge, the Pell Bridge, and the Jamestown Verrazano Bridge. No bill is showing as of right now, proposed for 2024. However, bridge barriers can not only physically prevent a person from jumping, but also are a sign of hope to people that the communities value the lives of individuals who are experiencing mental health crisis or suicidal thoughts. So we would like to just continue to advocate for this issue and see community advocacy until something like this is implemented, because bridge barriers and safety nets have effectiveness rates of 68.7 and 77.1%, respectively. So hopefully, either as a proposed budget item or as proposed bills, we would like to see this ongoing.
Thank you, Beth. Another priority that we have, and we see this as part of a prevention effort, is to establish a permanent working renewable Olmsted plan in Rhode Island. And we thank Representative Bennett and Senator DePalma for spearheading this effort again. An Olmsted plan refers to the 1999 United States Supreme Court ruling that said states have a legal obligation to ensure that people who live with any type of a disability or who are vulnerable to unnecessary institutionalization, they have a right to live in the least restrictive setting of their choosing, and the state has to ensure that that is possible for them. So Rhode Island is one of 6 states in the country that does not have any type of a plan like this. An Olmsted plan includes a statewide needs assessment. It includes looking at the supply and demand of resources such as supportive housing or transportation services for individuals with disability, home health care services, a whole host of resources that are needed to live our lives. And so what this piece of legislation does is it takes Governor McKee's Olmsted staff and planning body, or forthcoming planning body, I should say, and it makes it permanent, because right now it's not permanent in the law. And the whole point of an Olmsted plan is that it's renewable and it's constantly guiding the state as to looking at what we need and how we'll get what we need and what resources do we have. And so there's really no point in having an Olmsted plan for 2 years. You really need it to last in perpetuity for it to make a difference and do what it's supposed to do. So this piece of legislation makes it permanent, and it also lists the community partners that would be part of a permanent Olmsted committee to make sure that all of the various populations who would be affected by an Olmsted plan have some representation on the Olmsted planning body.
Doing nothing is not free. In summary, we respectfully encourage our leaders to make greater investments in our mental and behavioral health care system in Rhode Island. Immediate access to services improves patient outcomes and saves money. When patients access treatment in a timely fashion, their conditions stabilize or improve, thus decreasing the utilization of expensive emergency departments, inpatient hospitals, and residential treatment centers. When Rhode Islanders with serious persistent mental illness have stable and supportive housing, the rates of arrest and incarceration decrease, and we reduce the overutilization of law enforcement officers, courts, jails, and prisons, ultimately saving money. Doing nothing, I again say, is not free. We will just have to pay the price later. Most importantly, our neglect dehumanizes Rhode Islanders who are living with disabilities. We are good people with big hearts, and we can do better. We included this photo on this slide. It's from a past rally that we had a couple of years ago for Mental Health Month. And I want to highlight the top left poster, Spending Equals Values, Fund Behavioral Health. It is necessary to allocate resources to reflect the values that we believe Rhode Islanders hold in their hearts for all of us.
So each of us here today can do something to help move these pieces of legislation along. Each of us can do something to let our elected officials know that behavioral health care is important. Behavioral health care saves lives every day. So if you are an elected official here today, we respectfully encourage you to support these bills, to advocate for the state budget funding for the items we talked about, to get $1 million back into the state budget, to improve bed capacity and staffing capacity at Eleanor Slater Hospital. We look to you to work with the behavioral health community on these priorities. And tell us as advocates how we can be helpful and support you in the work that you're doing at the State House. We also encourage our elected officials to sign up for Mental Health Association and NAMI Rhode Island's newsletters and subscribe to our social media pages. And we really hope you'll participate on an advocacy event happening on May 1st. It coincides with the kickoff of May is Mental Health Month, May 1st at the State House. After the speaking program, we're encouraging every attendee to meet their rep and senator on the House and Senate floors, and we hope our legislators will be there to greet your constituents. If you are here today as a community participant, as someone who's doing this work, or maybe you're someone who's here to learn more and you have lived experience, or a family member with lived experience, your stories are really powerful. Your stories, your lived experience move elected officials. They increase understanding and increase empathy, and your stories, we hope you will share them. Please participate on Advocacy Day, May 1st, to talk with your legislators about why these bills are important to you, your family. And again, stay in touch with Mental Health Association and NAMI.
This slide here has our websites, email addresses. This is how you can best get in touch with us. It's also how you can learn about the programs, services, and advocacy efforts we provide. And on our websites, you'll also find our handles for social media.
And again, I invite everyone to join us on May 1st at 1:30 at the State House, second floor in the State Room. We'll be presenting awards to 2 Legislators of the Year and 1 Mental Health Hero of the Year. And the speaking program will go from 1:30 to 2:30. It includes Barbara Morse from Channel 10 News. She is a wonderful speaker and often shares her story, her family's story. And she's so passionate and compassionate. We're just so grateful to have her there. And then from 2:30 to 3, we're going to have a very brief Advocacy 101 training so that we can maybe touch on some of these priorities again with the audience, and also give you some pointers about how to talk to your rep or your senator on the floor. And then we'll help you find your rep and senator on the floor so that you can have a brief conversation with them. We hope to see everyone there.
We are now going to open up the forum for questions and comments. If you could please use the hand raise tool or drop your comments in chat. And I'm also going to skim through the chat to address anything that came up while we were presenting. So Lori, would you just keep an eye for hand raise? We do have some questions around whether or not we'll be able to share these slides with folks who are registered. And it looks like we can do that. There was some information that was dropped in on a webinar on CCBHCs. If anyone was interested, skim back for the registration link on Eventbrite. And also there's a comment regarding the Olmstead bill in the House 7821, which is scheduled for a hearing tomorrow. You can submit testimony in support of the bill, and there is an email address in the chat where you can send that. I do not see other questions. Lori, do you see anyone with a hand raised?
Yes, Quentin.
Afternoon, everyone. I just wanted to call some quick attention to two other bills that have a pretty negative potential effect on folks' mental health. So Senate 2703 and House 7884 are both regarding the prohibition of gender-affirming care for minors. This has an extremely profound negative potential impact on the mental health of our youth here in Rhode Island, as we know that gender-affirming care is evidence-based, life-saving, and absolutely crucial for these students and young folks that are experiencing gender dysphoria. So I highly recommend that folks submit testimony in opposition to these two bills as well.
Thank you. I see Clara Hardy, you have a hand up?
Yeah, I actually put something in the chat. I don't know if it got into the chat, but I am in private practice and I take a dual complete insurance, Medicaid and Medicare, and I'm having trouble getting reimbursed by Medicaid. And so I've talked to my representative, and he hopefully is going to be submitting a bill. I can't sustain as a private practice uh, social worker when I can't get paid by the state Medicaid program. Medicare is the primary payer and they'll pay me what they want. And then there's co-insurance and deductibles, which is crazy because they're all Medicaid clients. And so obviously I'm not going to charge my clients for co-payments. So Medicaid really needs to step up. I'm losing money. I mean, some of the time I'm not even getting paid because of deductibles. And I'm frustrated, I'm angry. I chose to work with Medicaid and Medicare clients, and I can see why people don't want to because you can't make a living. So I'm hopefully going to, I'm working with my representative and the NASW to try to help submit a bill, because most of my clients are already affiliated with the community mental health agencies. They just don't have therapists to see them. So if I would be able to get reimbursed if I work for a community mental health agency, but I don't. I work in private practice, but I see their clients. So it just doesn't make sense to me. And as you can tell, I'm very frustrated because it's just not fair that Medicaid will only reimburse certain providers. And that is something that really needs to be, because it limits people from taking Medicaid clients, and that's just unfair to people that really need the services. So that is my comment. I don't know if anybody is also working on that, but I definitely am trying to get a bill proposed to get Medicaid to reimburse private practice clinicians. So.
It looks like there's another provider who echoed those same feelings in the comments. So. And there's also a question regarding the counseling compact and the status of the counseling compact. I do not have an update on that. Lori, do you?
I can find one in a second and get back to you.
Thank you. There's also a comment showing that fear about the Medicaid enrollment bill. Excuse me, I just lost my channel. For incarcerated individuals would have a minimal impact without adequate funding for proper discharge planning at the ACI. That's a fair concern. The commenter says that their experiences in working with recently incarcerated individuals with serious and persistent mental illness and heightened risk for suicide suggest discharge planning is happening at minimal basis at this time. That is something we will also be keeping on our radar. We hear a lot about discharge planning anecdotally, so if there are specific concerns or specific things falling through the cracks that we should know about, please bring those to our attention as well.
The counseling compact bill was heard in House Corporations in January, and it's just been held for further study, which means it's just been paused. And if you wanted to contact the sponsor, it would be Representative Fogarty. And he might have more insight as to whether the bill will move forward with a vote in the committee or not.
you have a bill number for that?
Yes, I can put it in the chat for you. It's 7141, but I'll link the bill for you.
I don't see any additional questions in chat or hands raised.
Thank you to the providers who spoke up today and shared your experience, and thank you for accepting clients with Medicaid. You're really doing good work, and you're helping individuals who may not otherwise have access to behavioral health care services. Thank you very much. And if your representative does in fact introduce legislation, please email Beth and me and let us know so we can track it and encourage people to testify in favor of it. I can do an action alert to the behavioral health provider community. And I just want to kind of repeat what we were talking about earlier with reforming solitary confinement. I don't think I did a great job explaining why it's so important, but it's really close to my heart because psychologists consider solitary confinement to be psychological torture. And individuals who spend time in solitary confinement, when they are released back into the community, they're often psychologically harmed or traumatized from that experience, and it further impacts their mental health. And it makes it more difficult for them to stay in the community. And so, again, it increases the recidivism rate, and it's also inhumane. And I'm really hoping that the solitary confinement legislation will move forward this year. And I encourage you all to write letters to your elected officials and let them know that it's immoral that we're doing this to individuals in 2024. And again, we thank you so much for listening to this. And there were many, many more bills Beth and I could have shared with you. Ones related to protecting the rights of our transgender Rhode Islanders, and ones related to mobile crisis units, or expanding access to free school breakfasts for young people, because of course there's an intersection between nutrition and mental health. There are so many pieces of legislation going on, and we encourage you all to reach out to your elected officials and let them know what's important to you and your family members, because organizations' reach can only go so far. Elected officials really need to hear from their constituents, the voters. You all have the power, and I hope that you'll use your voice this session. So stay in touch. And again, we really appreciate your time today. If there are any last minute questions or comments? Seeing none, I want to thank you all for coming, and have a great day, and hope to see you May 1st at the State House.
Thank you, everyone.
Woo!
Thank you.